Potential problems. We talked about the operations. They're done laparoscopically or minimally invasive. 30 to 45 minutes for the operation. It seems like there's, not much to it, but they are major operations. They require a general anesthetic, and inside, even though we're using little incisions, inside there's quite a bit going on, especially with the bypass. We're cutting through things, we're moving things around. So for bypass patients, most patients have no problems at all. 94% have no issues. The majority of the remaining patients have what are considered minor problems, wound infection, something we treat in the office, but it's something we just got to be aware of. Something called a stenosis or a stricture. Usually 1 or 2, 3 people out of 100 will get a tightening of the connection between the stomach and the small intestine because as our bodies heal, in some people the body overheals and that shrinks. So when they try to eat or drink, if it's too small, they have difficulty. It takes about 4 to 6 weeks for that to occur because the scar tissue takes that long to build up. If it does happen, it's a fairly straightforward fix. It's an outpatient procedure. We go in with a camera and a balloon and blow it back up. So it's just something we have to be aware of. Bleeding and ulcers with bypass. Ulcers, it's important with patients who have gastric bypass. Medicines that can cause ulcers now, like aspirin and ibuprofen, they have a higher risk of causing ulcers after having bypass. So you want to avoid those medicines, aspirin and ibuprofen. The big thing though with bypass and ulcer formation, biggest risk factor is smoking. So I know you've heard it 100,000 times for those of you who smoke. If you smoke and you can't quit, you would need to quit for the rest of your life because an ulcer can come a month or 2 months or 2 years after surgery. You shouldn't have gastric bypass. Ulcers can cause many problems. They can bleed, they can erode all the way through and cause a perforation, which would require life-saving surgery to fix. So we want to avoid ulcers as best we can. So smoking and gastric bypass don't go together. If you smoke and you can't quit, then one of the other 2 operations, the band or the sleeve, don't carry that risk factor because the small intestine's not connected to the stomach like it is with bypass. So you shouldn't have gastric bypass if you continue to smoke. And then talking about the major complications, one is something called a pulmonary embolus. Some of you may have heard that term before. It's typically a blood clot that starts in the legs, forms in the legs, breaks off, travels through the vessels up to the heart and lungs. If that blood clot is large enough, it can cut off oxygen supply, and it can actually cause death in rare instances. It's pretty rare, but it's something that can happen, so we want to do our best to avoid it. The best way to avoid it is to prevent the blood clot from forming in the first place, because if we can prevent the blood clot from forming, then it can't break off and travel to the heart and lungs. So, risk factors that are there for blood clot formation: obesity, surgery. 2 strikes against us already, so we got to do our best to try to prevent the other things. The biggest risk factor by far, though, is inactivity, lying around doing nothing. So, years ago, when these operations were done and they were done the old way with the big incision, it was fairly painful. It wasn't uncommon to lie in bed for a couple of days. Well, lying in bed for a couple of days plus surgery plus obesity, that's big risk factors for blood clots. Nowadays, we rarely ever see blood clots because with the newer operations, you will be up and walking a few hours after surgery. Once the anesthetic wears off and you're awake and alert enough to get up and be able to walk, the nurses will help you walk around, and early walking after surgery is the best way to prevent blood clots. So that's a very rare occurrence now. It's not 0, but it's very low. It's next to 0. The other major complication that we want to do our best to avoid is something called a leak, a gastrointestinal leak. In bypass, we're cutting through the intestines, we're moving them around. So we connect those things together. Those connections have to be air and fluid tight. The intestinal fluid has to stay in the intestine. If those connections break open and the fluid leaks out, that's referred to as a leak, and that's a problem because that fluid has bacteria and stuff that the body can't deal with. A leak is only a risk around the time of surgery, right around the time of surgery and while it heals. So at the time of surgery and for about a week after surgery while everything's healing. It's not something that happens a month or 2 or 6 months after surgery, but something we got to be aware of around the time of surgery. The chance of a leak depends on really where you go in the program. So it's very important for someone to choose the program wisely. The experience of the surgeons is very important. There are a lot of qualified programs to have the operations, but in early studies, the leak rate was as high as 1 or 2 out of 100, and that's very, very high. Since the advent and the onset of centers of excellence, which has been a very good thing for obesity surgery, the leak rate should be more like 1 in about 500 or so. So it's not 0, but it is very low. And so it's important to go to a program that's experienced with that. Our leak rate in our program is actually extremely low. We've only seen a few and a few thousand, but we've done over 3,000 bypass operations, so we are very experienced. But it's important to choose a program that has experience with gastric bypass. So moving on to the band. Same thing with band. Most patients have no complications at all. Some will have some of the minor complications like we talked about, a wound infection, but not very much so in the band because we're not cutting through the intestine. There's no bacteria really in the field, so it's a less chance. The blood clot problem is even less in band because they tend to be more active because leaving less discomfort than like the bypass patient. The big difference between the band though and the bypass as far as major complications go would be the leak because we're not moving the intestines around, we're not connecting them and doing that. So the leak potential in the band is really, really next to 0. Anytime you have surgery and instruments are used to move the intestines around, that's always something that's listed as a consideration, but that's really the big difference between the band and the bypass or the sleeve is that we're not cutting through anything, so the chance of a leak shouldn't be there. What is there for the band that's unique to it is because there's a foreign body, that band is wrapped around the upper part of the stomach. The stomach is a muscle, and that band can actually slip on the stomach or the stomach can work its way through the band, and it's called a gastric prolapse or a slip, but that tissue going through the band potentially causes a blockage where it may require an operation, not always, but it may require an operation where we go back in and pull the stomach back down through the band and fix that. Chance of that's pretty low. It's about 1 in 200 roughly. But again, it's something we have to consider. Another thing that's unique to the band, because it's a foreign body, is the band can actually work its way through the outside of the stomach to the inside of the stomach through a process called an erosion. An erosion is kind of many feel that it's kind of a rejection of the band and the body fighting the band. Chance is very low. Chance is about 1 in 600 to 800, but it's still something we have to consider. If someone gets an erosion, it's typically a chronic process, so it's not an emergency type of a situation. However, it may require removal of the band in order to let the stomach heal because that hole that's in the stomach needs to heal. And that's the good thing about the band is the band can be removed fairly simply and the stomach can go back to itself and heal it and like as if it was never there. The next operation, the sleeve, again, like the other two, it kind of falls in between the two as far as complications go. It's more involved in a band, so we are cutting the outer part of the stomach out, so there is that chance of, if it doesn't heal, of a leak, but it's less so than a bypass because it's not as involved as a bypass and we aren't moving the intestines around. So again, the risk of the potential risk of the operations, the bypass is the most involved, and then the sleeve, and then the band. The upkeep after surgery, band more because we have to keep the balloon where it needs to be. Then the bypass because we need to check and make sure the vitamins and whatnot are okay in the blood. And then the sleeve is kind of the one that would be the least maintenance after surgery. Each operation has some uniqueness to itself. Again, the operations, the criteria is essentially the same. There are some patients who may have medical problems that may dictate one operation may be better over the other. In general, though, criteria is the same for each of the operations except for the BMI being lower with the band.